Welcome to Sanderson Firm's April webinar. I've got a couple of awesome colleagues and guests on with me today. So I'm going to go ahead and share the slides here momentarily, but just want to kind of give a couple of, housekeeping items before we get started. And I have these two folks introduce themselves. We will have a survey post this event. If you've been to the last couple of them, there might have been some issues with the surveys. We do have one today, so please fill it out. It's just a couple of questions at the end. We do take your suggestions very seriously. If you've got topic ideas, you want us to expand on something, let us know. The slides will be available. We will email them out. It does take a little while in post-production to edit the video and clean it up. But once we have that done, we will send out a follow-up email with a copy of the recording and the slides. So watch for that. And with that, I'm going to turn it over to Kayla and then Bridget to introduce themselves while I pull up the slides. Kayla?
All right. Hi, everyone. Good afternoon, morning, whatever it is where you are. My name is Kayla Pigeon. I am one of the attorneys here at Sanderson Firm, VP of MSP Compliance over a couple different departments. My background, I started Medicare compliance right out the gate. I like to say I grew up Medicare essentially. Worked at a large insurance carrier prior to coming to Sanderson Firm after getting my law degree. And excited to talk to you about coordination of benefits today. Bridget?
Thanks, Kayla. And hello, everyone. I am Bridget Smith, and I have been in the Medicare compliance world for a very long time, and started out as a defense attorney in workers' comp and general liability. And then someone said, you want to investigate Medicare? And here I am after all of those years. So my role and goal here at Sanderson Firm is to help clients navigate these Medicare waters through Section 111 and conditional payments and Medicare set-asides and help build programs that are Medicare compliant. And I am the Senior VP of Legal Strategy here, and I'm very happy to join Kayla on this presentation.
Awesome. Thanks, folks. So we're doing Medicare coordination of benefits in action, streamlining claims, minimizing denials. We know this is a hot topic, so if you have questions, please throw them in the Q&A specifically if you can. If we don't get to your question, either through the content that we're presenting or with maybe a little bit of time at the end for Q&A, we will follow up and answer those via email. So please go ahead and do that as we go. If this is your first time joining us, just a little bit about us. We provide unmatched, innovative Medicare secondary payer compliance expertise. That's us. We work nationwide. We're a law firm. Heather Sanderson founded us. So we are woman-owned, and we are comprised of legal, clinical, and claims professionals. At this point, we have over 80 employees now and more than 700 years of combined experience in MSP. So you're in good hands with us. I'm going to run through the agenda quick, and then I'm going to turn it back over to Kayla and Bridget, and they will be going over all of this stuff with you. So for the agenda today, we'll talk about just an overview of Section 111 reporting, because that does seem to be the catalyst that sort of causes these issues when it comes to coordination of benefits. And while there are coordination of benefits, there's a purview, right? It's built into the statute, it's built into the regs when it comes to conditional payments. Really what we're talking about here today is what happens when claimants call you and they're getting denied care, right? There are ramifications. Even if you're doing everything right via Section 111, there could be downstream ramifications that could cause a claimant to call you. So that will be our main focus, but we'll kind of do that overview to level set. We'll talk about the interplay with coordination of benefits, and then how to review and update a claim for coordination of benefits accuracy, and then what resources and materials exist to help the insurers and the beneficiaries with coordination of benefits. We'll talk about MAP and Part D coordination of benefits, because like we said, there is an impact with conditional payments. And then what happens, that interplay with settlement. So turning it over to you folks, take it away.
Thanks, Annie. And so as Annie said, Section 111 reporting is one of the pillars on how CMS coordinates benefits for beneficiaries. And that information that you give to Section 111 regarding the claim is really what CMS uses, or one of the resources that CMS uses to figure out who's responsible for paying, what should be paid, what shouldn't be paid. and what onus is on the beneficiary. So we really need to kind of start with Section 111 reporting, because what you put into it is what CMS and the beneficiary take out of it. And the whole reason that CMS created Section 111 reporting was to help with that coordination of benefits, so that it would receive information from insurers, self-insureds, workers' compensation insurers, no-fault insurers, liability insurers, to evidence when they were responsible for payments and when that responsibility stopped. And so really it forms that basis for that information. And it's really important, as Annie said, that that information is accurate, because it really impacts the beneficiary. So, okay. So part of reporting, right, is that you only report when someone is a Medicare beneficiary. And the reason for this is that benefits aren't coordinated and benefits aren't paid through Medicare unless an individual is actually on Medicare. So CMS doesn't care about people who have a reasonable expectation or are not Medicare eligible. They want the people that are on Medicare, and they want to look at those cases and claims. And what CMS did and provided to us was a tool in order to determine if someone was a Medicare beneficiary, and that's the query tool. Now, we know in general, and we've always known this, that an individual who's 65 and older is Medicare eligible. But something that a lot of people can overlook is the fact that there are individuals with disabilities who are on Social Security disability, have Lou Gehrig's, end-stage renal, who are also Medicare eligible, can also be Medicare eligible after a period of time for Social Security disability benefits after 24 months. So it's not just age that provides that Medicare beneficiary status. So that query process looks at the data you give them, right? They look at the first name of the claimant, the last name of the claimant and plaintiff, date of birth, Social Security number, and the gender of the plaintiff or claimant. And then they take that information and they show you via correspondence from them, a response file from them. They show you if that individual comes up or is locked for Medicare beneficiary status. They also show you what types of plans that individual has been on for the last 3 years. So a Medicare Advantage plan, a Part D plan, traditional Medicare, and all of that information is important, because once that occurs, once you know somebody's a Medicare beneficiary, that's when you're actively reporting. That's when CMS is documenting their files to make sure that things are being paid correctly and they're not paying when they shouldn't be paid. And that's where a lot of coordination of benefit issues come into play. And so one of the pillars also for Section 111 reporting, you report a lot of information. But one of the first things that you report for Section 111, if you're in work comp and no fault, usually not liability cases, you're reporting when you start to become responsible for medical. And that's called ongoing responsibility for medical, or ORM. And CMS wants to know when that occurs, because that for them ticks off the box to show, hey, wait a minute, we have another primary payer. We shouldn't be paying. So that beneficiary no longer can rely on CMS to pay for medical expenditures. Now you are telling CMS that you are responsible for those medical expenditures. And ORM is not established just when you get a medical bill. It's when you assume that responsibility for medical, right? So that's when the clock ticks. It's based upon the date of injury. CMS is then looking at, from that point on until you tell CMS something else, they're looking at you to pay for those injury-related expenses, because you're telling them, I'm responsible for medical. Here's who I'm responsible for. They're a Medicare beneficiary, and these are the injuries I'm responsible for, the diagnosis codes. CMS is using all of that to coordinate benefits. You're putting ORMY in there, and that is the starting point, the clock's ticking. Not all of your cases are going to have ORM, but realize when you put ORM in there, obligations change for that beneficiary when it comes to Medicare. Medicare no longer is the primary payer for those injuries. Now I'm going to punt it over to Kayla to talk more about ORM.
So Bridget kind of really laid the groundwork here, right, in terms of what is Section 11 reporting, the fact that how is it being used to coordinate benefits. But the situation really we're getting at today is when we're sitting at an adjuster's desk and a beneficiary is contacting you or potentially contacting an employer to let you know that they're being denied medical treatment. And that medical treatment is going to be a situation where it's unrelated to their workers' compensation claim or no-fault claim, and they're being denied that care. And basically what we're here to tell you and here to walk through today is that's happening because of that Section 11 reporting, that information that we're telling Medicare that there's some other insurance involved here that they're trying to coordinate benefits with. And this can sometimes be happening because there's something wrong with our Section 11 reporting, and we're going to go through examples about how we're going to review and look to whether or not updates need to be made. But it could also be situations where our reporting is 100% accurate. We've done everything that we needed to do, and that coordination of benefits issue is either happening at the provider level or actually at Medicare's level when they are saying that this is truly related. So again, this situation happens where that beneficiary is getting that denial. If we have an ongoing responsibility for medical open, so that's being reported to Medicare, and when that beneficiary actually goes to their provider to treat, that provider is going to see in their system that there is a open claim, whether it's for workers' compensation or no fault. They're going to see that coverage open, and that can potentially cause that coordination of benefits issue. Another big theme that we're going to talk about throughout the presentation is this idea of closed claims. Really, really important throughout the presentation, and just in general, a takeaway here is just because your claim is closed doesn't mean that one ORM is terminated, so you may still have ongoing responsibility for medical, but it also doesn't mean that there isn't going to be ongoing coordination of benefits issues. And actually, that's the biggest area where we're going to see coordination of benefits issues develop, is situations where it's a claim that's been long closed, but for whatever reason, that ORM is remaining. We're going to go through each of these examples in more detail, but to kind of lay the groundwork of these examples that we're going to give you. The first situation is going to be when we have ORM, so ongoing responsibility for medical, marked as yes, and maybe that shouldn't be the case or should be the case, and how that affects coordination of benefits. We're also going to dig in a little bit more into that ORM termination, right? As much as we need to be telling Medicare that we do or don't have that responsibility and there's that obligation to coordinate those benefits, we also need to tell them when that obligation ends. Section 11 is how we're keeping Medicare apprised of where we're at in that claim. And if we don't terminate that ORM, we could be creating unnecessary ongoing coordination of benefits issues. Bridget touched on ICD codes a little bit too. Again, Section 11 reporting, we're telling Medicare what this injury was for, and they're using that information. If within that information, we're not accurately telling them what the injuries were, they don't know if they should or shouldn't be paying for this situation. And we're going to dig into some deeper examples of that. And then towards the end of the presentation, we're also going to talk more about some more nuanced or more complicated situations. Benefits coordination, I think, is a tough issue for everyone out there, all the adjusters and carriers and TPAs, because it can get really tangled. Reporting can be really complicated, and some of these issues or reasons that benefits are being denied can just rise to this extra level of investigation needs. Some of that can be due to incomplete information in our reporting, but also this idea that there are these key data fields, and those fields needing to be accurate in order for updates to reporting to be happening. Again, we're going to dive into each of these a little bit deeper, but that's kind of the groundwork again, right? How is this ORM interplaying with the coordination of benefits? So this is our first example that we're going to give you, which is really around when ongoing responsibility for medical is yes, and we're having that benefits coordination issue. So in this scenario, Jane is injured outside of work, and her work comp claim is completely denied. Due to automations in the system, Jane's claim is automatically reported as ORM yes when she becomes a beneficiary. When Jane goes to treat for that injury next and bill Medicare, her provider's office lets her know that work comp is listed as her primary insurance, so her treatment is denied. And then she contacts you all. A couple things in here that are important. One, we're utilizing a situation of automation. And automation will come up a couple times throughout this presentation. Automation is fantastic. when it's working appropriately, right? But there are some situations where we see automation can certainly cause some nuanced issues in terms of coordination of benefits. So in this situation, something we see really happen very often is, maybe Jane suffered this injury, that claim closed. She wasn't a beneficiary at the time. Years later, when she became a beneficiary, stuff in the back end in our system causes that claim to be reported. And now it's creating that coordination of benefits issue, and we want to go back and review. In this particular situation, there's no need or reason for ORM to be reported. So the best way to handle this is to actually file a delete for that record, right? So this is a situation where ORM is yes, and we want to delete that record because ORM should be no.
Before you turn it over, I just want
Yeah.
to talk about this for a second. So, you may hear, right? Like never delete a record, like deletions are really bad. If I have too many deletions, it's going to create an issue with my EDI representative at CMS and they're going to call me. Yes, it is true. Medicare gets, they'll look at you a little like side eye if you've got a lot of deletes coming through. But at the end of the day, if you need to send a delete, you need to send a delete. This is the other thing too. Deletes have historically been kind of bad in this world. They're not all bad. You absolutely want to use this sometimes. The other thing that's sort of been frowned upon too, or maybe drilled into folks' head, is like ORM is not an on-off switch. You don't turn it on and then turn it off. You have ORM and then you terminate if you have a basis to terminate. That is true by and large with cases when you've admitted it and you need to turn it off because it's closed or whatever it might be. But in this situation, you do flip the switch off. Like the facts laid out here say that this never should have gone. I've also seen situations where folks have baked in logic and automation such that if they ever paid any medical on the claim, ORM is switched to Y. And oh, by the way, their system codes IMEs as a payment of medical. So you're doing, you have your complete denial out there. And I'm a recovering defense attorney too, like Bridget, right? So I've got a fully denied claim. You didn't pay any medical, you didn't pay any benefits. I'm defending you. Everything's going great. And then you go and you pay for that IME. I hopefully wrote up a really good letter to your IME doctor spelling out what we all need. And then it gets coded into your medical expense category and boom, this flag goes into yes. Again, this is another time when you would send a delete. You may have heard in the past, like, oh, well, just leave it as 1 day of ORM. You open it the 1 day, you close it to the next day. No, you do not want that, especially if you think about it, right? I've defended claims and I've worked on claims in the Medicare world where they're catastrophic. So day one, that person was evac. There was a medical evacuation, right? If you have 1 day of ORM, guess what? You become responsible for those conditional payments. So it's really important. Yes, you're not going to send deletes all the time, but this example that Kayla outlined for you, this is absolutely appropriate to process a delete record. And in these situations, if your system has automation that kind of works against you, it works for you most of the time, but it works against you some of the time, those are appropriate scenarios for deletes.
Yeah.
All right, Bridget, over to you.
That's great, Annie. That's really important stuff because sometimes we have to have catches if those things get through the net, right? And so it's important to kind of figure out if that's happening as well. And one of the things that is so hooked up with all of this is there's a lot of emotion that goes into these denials, right? You have a beneficiary on the line saying, I can't get treatment. And sometimes the treatment is for something extremely important, extremely time sensitive, and you're working to try and help them resolve this. So really, it takes a village sometimes, and knowing what you can do to help is important, and maybe some gaps as well. So with that, ORM termination, the other part of this, right? We said you're telling CMS when the clock starts to tick for ORM, right? You're on the hook. That beneficiary goes to the doctor. The doctor's going to look to you if it's an injury that you reported to pay for that. You also want to tell CMS when you're no longer responsible, right? Because if an individual, if a claimant or claimant goes to treat and you're no longer paying. And then they go to a doctor's office and the doctor says, "Oh, wait, you have somebody who should be paying for this. We have this on in our records, in our system." They're kind of in a limbo situation. And so ORM termination is really important. Now, ORM termination with respect to when to terminate ORM, CMS has given us some pretty specific guidelines, per se. A new reference guide came out last week, which we'll talk about in a second, just very briefly, because that's not the purpose of this presentation, but it does impact this a bit. But ORM termination is not just case closure, right? There has to be something that is the impetus for ORM termination. So we know that you can terminate ORM if the claimant passes away, obviously, if there's a policy exhaustion, if you settle the claim, if there's a statute of limitations that has run, if you get a treating physician opinion saying that no further medical treatment is needed, if you pay and then issue denial after that and stop paying. Those are some of the reasons that you can terminate ORM, right? You settle the claim, you settle the medical portion of the claim. You can terminate ORM. There's a definitive reason why that obligation stops. CMS also came out with another criteria because CMS realized that there are some jurisdictions where you can't close medical. They're open for the life of the claim. So they said, we want to give those individuals, these jurisdictions, opportunity to close medical when it's makes sense, right? When there's really nothing going on that would require us to keep ORM open. And so they gave us these guidelines for it. So these only apply to claims that don't involve ingestion, implantation, or exposure. The reason being those types of claims, there is treatment that's going to probably last the life expectancy of the claimant, so you wouldn't close those. No claims were paid for medical within the last 5 years, right? So you have a period of time where nothing's happening, nothing's being paid on that case. Treatment does not include a prosthetic or implantable device. Again, that would be a situation where an individual is going to require probably revisions in the future. So closing ORM, terminating ORM wouldn't be feasible in that case. And the total amount of medical paid on the claim does not exceed $25,000. So what we're really talking about here is those claims that are not injuries that are kind of in the nature of exposure injuries, that have implantations, that not a lot was paid on, that there's not a lot of activity, or no activity, I should say, within the last 5 years. You can terminate ORM for that reason as well. So the only caveat with this is that if anything changes, you have to go back in and again report ORM. So that's very important. Well, CMS also came out with the new guide, and they added a little bit of additional language here, and I'm just gonna read that. They said, in addition to ORM being terminated by an insurance contract, such as maximum coverage benefits, you can terminate for any other reason that is not prohibited by the terms of the insurance contract or applicable state or federal law. And then CMS notes, an insurer's refusal to accept ORM or to continue to accept ORM is a valid ORM termination reason, provided that the refusal is permitted by applicable state or federal law and the terms of the insurance contract. So what this will flesh out to mean, we will see. But with respect to that, we would note that you need to look at the totality of circumstances when you're looking at that criteria, right? What does that look like in your case? If it's based upon a denial based on medical, let's say an IME or something of that nature, what else is going on there? Is the claimant continuing to treat? Are you stopping payment at that point? What does the case look like? Document, 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 document. Look at the totality of circumstances, document what's going on, and realize that that documentation is going to be needed if and in the event you are audited by CMS and they question whether you should have reported ORM again at that point. So there is a little bit of a change, and we'll keep you posted on how that fleshes out, but we wanted you to be aware of it. The reason ORM termination, again, is so important in the coordination of benefits is that you're telling CMS, someone else should be paying for the claimants or the plaintiffs' medical treatment, and it is not us, and make sure those individuals pay and that you Medicare pay, or that those individuals bill you Medicare and that you Medicare pay for those treatments as well. Okay, we can go to that next slide, Annie. Okay, let's give an example here. And this is an example actually close to home because I too, like Mary, was sliced, not by a meat slicer, but by a mandolin and had to get stitches. So I understand Mary's pain. I did visit the ER, and it wasn't a work injury, unfortunately, or fortunately, I should say. And with respect to Mary, her adjuster ensured that there was some lost time medical benefits paid and marked the claim as closed in the system. Months later, Mary then visits her doctor for unrelated carpal tunnel treatment. The doctor tells her that the worker comp is listed as her primary insurance, so the treatment is denied. Confused, Mary contacts the adjuster who confirms the claim was closed and gives her the closure date. Mary then calls the BCRC to inform them. So in this situation, the adjuster didn't terminate ORM, right? And so, like I said, in the system to that provider, it shows that that adjuster, that insurer is still the primary payer. If you fail to terminate ORM, these are the things that are going to happen. And that's why it's important, because in this situation, it may hold up Mary's care. We're going to talk about a little bit how you can work with the provider to prevent that. But it's definitely important to the beneficiary, and you're going to get calls if you don't terminate ORM promptly, and do it based upon the date that is valid according to that criteria. Okay. And
Yeah,
Kayla?
well, and I just wanted to jump in here for a second too.
Sure.
Also, so yeah, what's interesting here is, okay, the adjuster didn't terminate ORM for her finger. Why is this provider not treating her for carpal tunnel, which is not a work comp injury, right? Your fact pattern doesn't say that, it says it's unrelated. So does she have a different comp claim for that? Or is that just maybe she, recently had a child and has developed carpal tunnel from carrying the kiddo around, right? We see that. It happens. One of the big things to keep in mind is that, okay, maybe the adjuster didn't terminate, ORM timely. Maybe the adjuster did enter it. We are reporting on a quarterly basis, folks. So it could be entered in the system and it could be hanging out there waiting to go in 135 days or 120 days. If they just reported yesterday and she terminates ORM today, it's not going to go for another 120 days. So it's not real-time information. And then what gets fed to the doctor's office comes from the common working file. And what we've seen, and Kayla's going to talk about this, I'm sure, some more, is like we've seen that the doctors misread these screens all the time. So that's also what happened here. The doctor said, we can't treat you for carpal tunnel because you have an open work comp claim. Doesn't matter that it's a sliced finger. I mean, it could be a hip, it could be a shoulder, it could be anything. They are misreading their screens. So even if you do everything right, you contact the BCRC, you get this information out there, there's only so much we can do with the provider's offices, misreading this.
Perfect. All right, so, Bridget really outlined the importance of terminating ORM, but another thing I want to stress is ORM termination is not always appropriate. And unfortunately, what happens when these beneficiaries' benefits are being denied, oftentimes they're calling Medicare and they're being told by someone on the phone, oh, you just need to have, your work comp carrier, whoever it is, terminate ORM. So they often, feel like that's the solution. That's what they've been told is the solution. And they're going to come to, us adjusters and say, hey, you need to terminate my ORM. But unfortunately, what's happened in those situations, Medicare's put us in a really tough spot because the situation might be that we can't actually do that in accordance with CMS's guidance. So it's really important that we're actually reviewing. There may be updates that can be happening, but also sometimes, like Annie talked about, it's really a provider issue and not something that is incorrect in the reporting. So really important, not all claims can be immediately terminated with Medicare. This is because, different jurisdictions have different statutes of limitations or no statute of limitations at all that we can utilize to terminate that ORM. They also might not qualify for that 5-year statute of limitations that Bridget outlined. I can tell you when that 5-year statute came out, like everyone was celebrating because it did get rid of a lot of these issues in those states that never had, had lifetime medicals where we couldn't terminate ORM. That helped in a lot of situations. I do believe there's still some movement in the industry to try to even broaden that further to be able to terminate ORM in more situations to continue to try to cut down on the amount of coordination of benefits issues that we're having. But really, we would love to terminate ORM. It is an easy fix. It is something that is one of the best solutions to stop coordination of benefits issues, but we can't always do it. So really, really important that we're actually reviewing the file, not just terminating ORM when beneficiary is telling us that we should. So really important that we're looking at those state-specific situations, and that we're updating the termination if it's applicable. And that update should really be happening through the Section 111 reporting process. But like Annie said, that Section 111 reporting process is quarterly. In order to have that happen as quickly as possible, we can also call that in to the BCRC and get that fixed on a more immediate basis instead of waiting for that quarterly report. So the next situation I want to talk about, and I saw that there was a question about this in the Q&A, is ICD codes and how that affects coordination of benefits. So ICD coding is going to be a really important area where we also see issues with coordination of benefits. Going to walk through a couple best practices and how, if these are not being followed, they affect that denial that's happening for the beneficiary. The first one is going to be, we want to keep ICD codes as succinct as possible. We want to be clear, concise, and specific about what the injuries are that we're accepting. Again, not to keep, picking on automation, but one of the situations where we see this go wrong can be if your claim system is automated to report the ICD codes that are on the first medical bill for that injury. That's something we see relatively commonly in the industry. And, you may or may not be aware, but typically, when you go into a provider and they're treating you for something, the first ICD code is typically what the actual incident is about. But a lot of times they're also including a bunch of other things, all of your comorbids, the history of, your health. If you have high blood pressure, diabetes, those types of things, a lot of times those codes are reported in there as well. And unfortunately, for using that type of automation, we're telling Medicare, we're accepting ongoing responsibility for medical for all of those things. So when that individual is going to go treat for all of their underlying conditions, as you do, that's when they're going to see those coordination of benefits issues. So really important that we are making sure that ICD coding is accurate in terms of what the actual injuries are that we're accepting ORM for. Another area where this gets tricky is using ICD-10 codes versus ICD-9 codes. So we used to use ICD-9 codes on some of these older claims, and ICD-9 codes are less specific. They're more vague. They don't differentiate, like one of the biggest things they don't do is differentiate between left and right. So if I'm the beneficiary and I have a workers' compensation claim for my left shoulder, and my workers' compensation claim reports just as shoulder, so it's not saying left, but let's say I get an unrelated injury to my right shoulder. When I go to treat for that, I'm going to have coordination of benefits issues because the report just says shoulder. So being as specific as we can, using ICD-10 codes when we can so that we're specifying left or right is going to be really important. The last one that's going to be, this is one of my, biggest things that I always stress in terms of reporting is not reporting just generally vague codes. My least favorite ICD code to see reported on a claim is chronic pain. If we're dealing with, Medicare eligible individuals who've had, likely many different types of injuries throughout their life, maybe they have all these underlying things. If I'm a provider or if I'm Medicare and I'm looking at the, Section 11 reporting that came through and it just says chronic pain, well, okay, everything probably can technically be related to chronic pain, right? That's going to create the most coordination of benefits issues. So really trying to keep those things to specific. So if it's a low back injury that's causing chronic pain, we want to report the low back and not chronic pain in that reporting.
And I would even take that a step further, Kayla. And I know
Yeah.
clients of mine have shared this too, right? Like they will not report the ICD-10 code associated to low back pain, right? What you should do is if it's a sprain strain, you pick the ICD-10 code that's related to low back strain. Because like you said, if they've got comorbid underlying things, I think of it with like shoulder claims, right? Somebody has underlying shoulder osteoarthritis or something, and then they tweak their shoulder at work. You definitely want to be putting in at the adjuster level or desk level that it was a strain sprain. Because if you just put in right shoulder pain, then all of their osteoarthritis treatment's going to show up. Sorry, Bridget, go ahead. You were going to say something.
No, Amy, on the same vein, the
Yep.
same thing, actually. We're thinking both alike. And I think ICD coding is probably one of the most important, if not the most important thing that you're reporting to CMS, because you are really telling them what to pay for and what not to pay for. And if it is too broad, you're taking on so much more than you have to. And another thing too that I always think of, like if I see someone who's reporting like 12 ICD codes and someone just got hurt with a sprain strain type of injury, I think, wait a minute. You're over reporting all of this. And so just be, obviously you want to be correct, but you don't want to be over redundant and too broad with anything. It's a fine line, really. But yeah, definitely be as specific as possible. Even disc levels, right? I mean, you just want to be specific, especially those comorbid conditions. And I think the other thing here too is don't look at the bills, right? And just use the bill codes on the billing forms, because it can include things like diabetes and hypertension that have nothing to do with your injury. So just be cognizant of that. And that's where we do find some mistakes with the coordination of benefits, a lot of mistakes. So
Bridget, I'm glad you mentioned that too, because that was something that was sticking in the back of my mind is in my past life, I've run into situations, right? So if you think back to how long we've been doing Section 111, so just so you want to orient ourselves, we've been doing MSAs for 25 years this July. Those came out in '01. '07, you start to see this movement for Section 111 reporting. It goes into effect by 2010. We all start living this life, right? So we're 16 years in. But if you think back to the world that we were all living in 16 years ago, as you're building out these systems, the bills, that was one thing, Bridget, that I saw some folks hard code in. It's like, oh, we're just going to have the folks who process our bills enter the codes in.
yep.
And
Yeah.
there's 19 slots for those codes. Less is more here, like what Bridget just said. You don't want 12 in there if you can avoid that. You less is more, get specific, note what you need there, but also do not use those bills. And if your system for some reason is still coded that way, hopefully you're aware of it and you can be pulling out the codes that shouldn't go through, because you throw in one code for hypertension. Yes, you paid it, right? You had to clear them for surgery. So you had to get them cleared. You paid for hypertension, you paid for diabetes treatment. Don't let that slip in. Or Kayla could attest to this. You're going to get a stack, like 100 pages of conditional payments. So yeah. All right. On to another example. What do we got?
All right. So moving into an example of my least favorite code being reported, John has a compensable workers' compensation claim for the low back. The carrier reported John's claim to Medicare with that ICD code for chronic pain. John needs unrelated cancer treatment. When John goes to treat and bill Medicare, his provider's office lets him know that work comp is listed as his primary insurance, so his treatment is denied. John contacts the adjuster. So this is, a pretty clear-cut scenario where chronic pain really didn't need to be reported for this low back, and how it's then affecting the denial for the cancer treatment. And, this is an extreme example, a situation where, I think Bridget talked about this a little bit in terms of the emotions that a lot of times surround these benefit denial scenarios. I can tell you, I've seen this example come through. And in this situation, it's clear that the ICD code could have been better. But what Bridget's going to talk about in a second is really what to do in those situations where, we reviewed and the ORM is correct and there is no reason for ORM termination and our ICE code is correct. And what do we do from there? I've seen this scenario play out where the workers' compensation injury was for that cut. We reported the cut and we have cancer treatment being denied. It's a drastic example, but it exists and it's something that happens. And it's typically happening from the standpoint of the providers just not reading the information that's there. So Bridget, I'm going to hand it over to you to talk about those steps and the resources that we have.
Great, thanks, Kayla. And yeah, that is a very extreme example, but it happens. And so like Kayla said, if you've checked your reporting, it is accurate, you've confirmed it's accurate. Some of the things that you can do, one is provide a letter to the beneficiary outlining how it's accurate, detail what you reported, why it's consistent with the claim. So they have something to show the provider, to have in their records if they need to correspond with CMS to show how this is not a reporting issue. This is either a provider issue or a Medicare issue. That's one thing. The other thing too is if it is a provider issue, provide the provider with a resource. And we haven't linked here the link to it. You can download it and print it out or send it to your provider via email. And it talks about, it's an MLN article, Medicare Learning Network article about how providers need to bill services correctly and how they should be continuing to treat these individuals and then appealing to CMS regarding denial of charges. So that definitely is a resource. And if all else fails, it may be a situation where the beneficiary will actually need to do the appeal with Medicare. And obviously that letter will help. And getting involved in that way will help. So it can be a process. We in all of the situations that we've had in the past or recently, we know that clients want to help. They don't want these situations. So everybody's on the same page and everybody's working towards a resolution. So these are some of the ways to resolve it.
So a couple other real examples that we're just going to walk through. We talked about the most obvious situations, right? ORM is yes when it shouldn't be, and that's causing an issue. ORM termination can be applied, so that will immediately relieve the issue. And then those ICD code situations where potentially we can update ICD coding to help that coordination of benefits process go smoother. After those sort of options are exhausted, or maybe we've also exhausted the situation where we're dealing with the provider, there's some other more complex investigations that might need to happen to understand what's going on or what's causing that coordination of benefits issue. One complex issue that I have run into a couple times are situations where we have previous reporting done by a third-party administrator. That claim moved to a new TPA. And the scenario was this. We had a person who had a workers' compensation injury. They were having benefits coordination issues, and they called and said, help. We were able to terminate ORM. Great. We did our review. We could terminate ORM. Well, 3 months later, they called again. Their treatment was being denied again. So that was, okay, interesting. Went back through, called it in, made sure it was terminated. 3 months later, they called again. And that's when we thought, okay, there's something else going on here. And the 3 months was the key. What we realized what was happening was that a quarterly update was happening somewhere. And as it turned out, that quarterly update was happening because of a previous third-party administrator that held that claim. Something that was going on in the back end was causing that claim to re-report on a quarterly basis. And every 3 months, this beneficiary would have that benefits interruption. So it ended up being a situation where we had to work with the previous TPA to get that updated and solve that situation for the beneficiary. As you can imagine, that was very frustrating for this person. We became best friends because we were dealing with this together. Every 3 months I was getting this phone call. But that's kind of that more complex situation where there might be other things going on that we need to dive in and untangle. Another really strange situation that happens, this is probably on my least common of situations that could happen, is if we're reporting a Section 11 report for an incorrect beneficiary. We've had situations where we can actually query with some partial information sometimes. If we have just a first initial of a first name and a last name and maybe a partial social, we've actually seen this happen where that connected to a different beneficiary entirely than who the claim was for. And so that completely different beneficiary now has a claim showing reported that didn't happen for them, right? And that can create coordination of benefits issues for them. That's going to be very uncommon. That, of course, also creates some interesting conditional payment issues that you may have to work through. Um, but again, just going back to generally like having this information be as complete and accurate as possible is going to be just really important to avoid these denials or these really specific, hard to understand or hard to untangle coordination of benefits issues. And then the last one that I'm going to talk about, and then Bridget's going to talk about a lovely sort of tool that we have to help with this is self-reports. So a beneficiary or that beneficiary's attorney can actually call Medicare and report an ORM. You might have a completely denied claim, which for whatever reason, that beneficiary somehow reports to Medicare that they have an open claim, and they can cause ORM to be yes when it really isn't. They can also terminate ORM when that shouldn't happen. And they also probably most commonly will report settlements that haven't occurred. And that can cause coordination of benefits issues as well. So I'm going to turn it over to Bridget to talk about how we deal with that piece of it.
Thanks, Kayla. Kayla is our Sherlock Holmes of conditional payments and coordination of benefits, as you can hear. So what Kayla is talking about is the unsolicited response file. So basically, an RRE can opt in to receive this on a monthly basis, and it shows when any of those types of changes that Kayla was mentioning were made by the beneficiary or the beneficiary's representative. So an RRE can look at this, they can see if any changes were made, and they can refute this if this is wrong information. So it's a good resource to opt into and to look at on a monthly basis just to make sure everything coincides. There's nothing in there that is inconsistent with this, what is actually going on in the file.
One thing I want to add, so I think most of you know if you've been watching us for a while, I served as I'm currently serving as the immediate past president of MSPN. We did talk to Medicare earlier this year and late last year. If you've been following these kind of issues, Medicare is back on track to be able to provide TPAs, like an RRE, a responsive reporting entity, the carrier. The self-insured data that's been previously reported by other TPAs. When you move TPAs, they
Yes.
are going to try to work on that, which will help with those issues. Sorry, keep going, keep trucking. I just couldn't get off mute fast
Good
enough.
No,
point, Annie.
great input, Annie. Yeah, that's a situation that just generally has been complex to work through in the past. And yeah, it's great that we're starting to see some movement there. Another place where Medicare is working on coordination of benefits and these issues is Medicare Advantage plans and Part D plans. In the past, these plans really weren't receiving much, if anything, of the Section 11 reporting, or if they were receiving it, they had no means of really ingesting that information. There was a lot of issues with them receiving the Section 11 reporting in order to coordinate benefits, in addition to all of the issues that we see with conditional payments. There were some changes made to this process in February of this year that we're hoping to streamline this process because CMS is really indicating that they want the plans to be coordinating benefits. They want the Medicare Advantage plans and the Part D plans to be coordinating benefits as well as traditional Medicare. And we're expecting that to increase greatly, especially given some of the WCMSA reporting, which Bridget's going to talk more about. We haven't really started to hear any sort of whispers of issues yet with coordination of benefits with these plans. I think it's an area we can expect to see more developments throughout the year as Part D plans and Medicare Advantage plans start engaging in more of this coordination of benefits. It is a sticky issue for them, however, though, because, really at the end of the day, Medicare Advantage plans, individuals have choice of Medicare Advantage plans. These beneficiaries are their customers and they would rather recover conditional payments and do that process than coordinate benefits and deny at the provider's office or at that pharmacy. So anyway, we did do a deeper dive into how some of this data going back and forth had changed in a previous webinar, which we've linked here for you all to review if you wish.
Okay, so settlement, the TPOC, total payment obligation to the claimant. That's also part of the coordination of benefits because that is when you're telling CMS that you've settled the medical portion of the claim, and CMS is documenting their file to show that, okay, you're settled. Let's look and see what benefits we paid in the past and what shouldn't have been paid, and going forward, what should be paid on the claim and what shouldn't. Now, part of that, as Kayla was talking about, and Annie as well, is the WCMSA reporting was added to TPOC reporting. So now, in addition to the settlement date and the settlement amount, you also have to add in the workers' compensation Medicare set aside amount and data fields regarding the life of that MSA, whether it's going to be funded in a lump sum or structured, whether it's professionally administered, and if it has a CMS control number. And we can go to the next slide, Annie, about that as well. And so it doesn't matter with respect to reporting WCMSA information, whether the case was submitted to CMS for review or whether it was not submitted to CMS for review. All that matters is that it's a Medicare beneficiary, it's a workers' compensation claim, and you meet the reporting threshold of $750 or more. So that's what we're looking at. So it's a very broad field that you're reporting to CMS on. And the important thing about this is that when you report that WCMSA information, it impacts the claimant in a lot of ways. CMS is documenting the common working file with that information, showing that there is an MSA and that MSA should be utilized as the primary funding source for that claimant post-settlement to pay for injury-related Medicare covered expenses. So if you have a wrong number for the MSA, if you put 2 million instead of 2,000, that's a big impact to the beneficiary. If you're reporting the wrong diagnosis codes, that's a big impact to the beneficiary. CMS has also given us some direction on reporting if you have a claimant who suffers multiple injury and you're settling the case and settling out all of those injuries. They've given guidance to report on that earliest injury, and they'll go back and coordinate all of these benefits. We need to see how that works. I'm not sure how that's going to work. We're hoping that it works well, and CMS is still talking about maybe looking at that a little bit more. But WCMSA reporting is going to impact the coordination of benefits post-settlement, and so it's very important that this information is reported correctly.
The comment about often seeing CMS denying in situations where the reporting is correct. And I really want to emphasize that often the beneficiaries are being given information that's not necessarily accurate. The providers are often telling them basically that it would be denied by Medicare, or that they need to, have their open workers' compensation record closed. And a lot of times that's not accurate. It is very, very rare, to be honest, given how many of these we see from a benefits coordination perspective, where it's actually CMS doing the denial. Typically, it's that provider just not billing correctly, and you'll want to refer them back to that that link that we included. That's that resource document for the provider that says you shouldn't be denying this bill. You should be running it through Medicare. Now, that's not to say it never happens. I have seen situations where it is actually CMS denying. But again, I would say considering the percentage of ones where that's the situation versus when it's really the provider, it's very minimal comparatively.
A really good point, Kayla. Thanks, everyone. I think we've answered most questions live or with responses. We'll answer some offline. There's some good questions coming in. But right now, stay tuned for our next webinar. Kayla will be featured again. We will have a guest from outside Sanderson firm. I'm not going to say a word about who it's going to be. Watch for the invite on that. We do have a date. It's going to be May 28th. So everyone, it will be summertime. We will be post Memorial Day. You will be refreshed from your long weekend. It'll be a little bit later in the week. Please come prepared. I mean, wear your, bring your beach balls, whatever it is. We'll be super excited to chat with you about Medicare again next month. If you want to be registered for these in advance, please email us at spotlight@sandersoncomp.com. We will get you automatically registered for all of our webinars. And then if you can't make it, you'll get that follow-up email. The follow-up email this time will have links to those two pieces that we had in here, right? That form is about a 7-page document that you can give to a provider. And then our past webinar where we did a deeper dive on some of these issues, please fill out the survey. It should automatically pop up after this today. We've got a list of our services. This will be in your packet, so you can take a peek at that. But we do all things Medicare secondary payer. And because we're a law firm, we're able to offer legal advice, legal opinion letters, that kind of stuff. Call us if you need anything. Lastly, we want to just remember to keep giving a shout out to MSP College. Kayla and I are both faculty for MSP College. We teach for the MSPA program. If you are interested in learning more about this, or you just decide that you want to be a Medicare nerd like the three of us, this is where you go. MSPA program. It's entirely online, designed for claims professionals looking to enhance this knowledge. It's on demand, at your convenience. Do it at your own pace. Please take a look at it and enroll if you're interested. We also, if you're more interested in learning about how Medicare set-asides come together and how that works really in terms of allocations and on your files, you can get the MSACP designation. It's again online, on demand, completed at your own pace, but we have these here for you through MSP College. I really, truly want to thank everyone today on behalf of Heather Sanderson and all of us at Sanderson Firm. Thank you so much for your time, your wonderful questions, your engagement. And thank you especially to Bridget Smith and Kayla Pigeon for all of your wisdom today. Thanks,
Thanks,
everyone.
Amy.
Thank you,
Thank you.
everyone.
Thank
Have a
you,
great
everyone.
day.
Bye-bye.